All right, welcome everyone to this month, which is July, NASCI's Curious Cases webinar. I'm Jacob Kirsch. I'm going to be hosting you today as we try to go through a few cases. I see a few names on the guest list, some friendly faces there. So looking forward with sharing some cases with you guys. And if you have some cases to share with us, just let me know. And I'll definitely share the screen with you guys. I don't have that many cases today, so I will need your help to try to take advantage of the time that we have together. First and foremost, I was presenting a slide about the NASCI's annual meeting coming up in September. As you all know, due to the current pandemic environment, our meeting will go virtual. So we're going to be seeing each other on the screens of our computers the weekend of September 12th and 13th. So the meeting is going to be on a Sunday and Monday. Make sure to register. It's a fantastic program, some really good speakers and great presentations. The Saturday before, the 12th, the Saturday, that's when we're going to have NASCI's Cardiac Imaging Bootcamp. Somewhat more basic lectures for those who are just starting to look at cardiac imaging, have an interest in cardiac imaging, or for trainees. It's a great environment for trainees to start getting used to seeing cardiac examinations. It's a multimodality cardiac imaging bootcamp. That's on September the 12th. That's a Saturday, and that is going to be free for all. That's going to be free access. You do not have to be a member of NASCI. You do not have to pay registration. The bootcamp this year is going to be 100% free and available online for everyone to participate. You do have to go through the website, NASCI website, and register. You will not be charged, but you will have to register for the bootcamp if you want to have access to the lectures September 12th. Again, that is the bootcamp right before the annual meeting on Sunday and Monday. Again, I invite you all to join us. It should be a fantastic meeting. We have some great speakers and some really cool sessions planned for everyone. So really excited about it, really looking forward to it. And without much further ado, let me start with a couple of cases, and then anybody out there that has a case they want to share with us, we can definitely go ahead and do that. All right, here we go. Might as well start with this case. And again, the cases that I have today are a little bit more show and tell, relatively straightforward, a couple of teaching points here and there. Please feel free to unmute yourself and give comments as you think appropriate. So a relatively young adult patient came in after some shortness of breath episode and came in for a CT angiogram. No risk factors for atherosclerosis. So low risk patient, but as you can tell here, let's go back here. Left main looks pretty good. You guys can see it there. As it bifurcates into the LAD and circ, it's a somewhat short and small circumflex artery, but then look at the right coronary artery. Significantly enlarged, very tortuous. You see it there in the right AV groove, going all the way down. And then you start seeing these tortuous also serpiginous vessels along the left AV groove, right there as well. And we continue following that down on the right, and we see again it goes down along the inferior AV grooves of the heart where the posterior descending artery comes off, and then it continues to be very redundant, very tortuous, and then starts to move up in that left AV groove, very tortuous, and then right there it communicates with the coronary vein, which we see right there crossing over across the heart. So a little bit larger even there, proximal to the fistula. Even there already seems to have some backflow of higher pressure system coming from the coronary arterial trunk. into a venous structure of low pressure system, which makes them get engorged and enlarged with time. And again, it goes down, and then the greater cardiac vein draining into the coronary sinus and the right atrium. So here we have a case of a young patient with a pretty significant coronary fistula, arteriovenous fistula, coronary arteriovenous fistula draining into the coronary sinus. And patient seems to have some other pulmonary issues with significant volume loss there at the left lower lobe and a pleural effusion as well. Just for completion's sake, let's look at some reconstructions. That's the right-sided system. You can see the right coronary artery coming out of the right cusp and how it courses downward towards the inferior wall of the heart, which is very tortuous, and moving upwards along just lateral to the mitral annulus. And there's a few communications with the coronary venous system. All right, so that's one case. Any comments or questions? Anybody wants to add anything to this? All right, so for those of you that see some of my posts in Twitter, I posted a short video on this patient. It's a post-op patient. I won't show the x-ray. We'll leave that for later. So let's look at the axials first. So this is a CT of the chest with contrast. It's non-gated. You can see the patient has a sternotomy, some changes of the prevascular space or anterior mediastinal fat plane. So probably somewhat recent surgical change to this patient. And we see the surgical change there. It's an aortic valve prosthesis. And what I showed on that Twitter post was just basically a short loop going through the aortic valve. There was a question, somebody mentioned if there could be some sort of fistula between the aorta and the left atrium. That is very good observation. But there's a lot of, probably here, there's a lot of motion artifact. Again, this is not an ECG-gated examination. We see there's some plaque in the coronaries. The heart's on the larger size, so some cardiomegaly and some atelectasis probably there at the basis. So I think this is a very nice case because it's really hard to tell when you look at the axials. I would say it's nearly impossible to come up with a diagnosis. So let's look at the coronal images. And see if we can come up here with a diagnosis. So there's the RVOT and the pulmonary artery coming up. There's the aorta, and there is your aortic valve. And you see there where how it's pointing towards the head or even slightly towards the left shoulder. Let's see if I can make this into a little bit of a thicker MIP for you to see the valve and how it's laying in the chest. So you see it looks pretty horizontal there, which is not the actual orientation of the native aortic valve. So this dehiscence of the aortic valve post-surgically, you can see here there would be some free-flowing flow and regurgitation lateral to the left lateral of that prosthesis in this patient. And what's very interesting is this was mentioned on the post-op chest x-ray. So you see the sternotomy wires here. It's kind of hard to see here, so I'm going to try to do a very narrow window. And you can see probably here, I hope you can see it. If not, you can see it better on the scout. I'll show it. The aortic valve is pointing in the right direction. Usually you can imagine the lumen of that valve pointing towards the right shoulder. Here is kind of pointing towards the left shoulder. Let's look at the scout. I think here you can see it a little bit better. And there's in the center, right, that aortic valve kind of looking in the wrong direction. So again, just I think we had the chest x-ray, they kind of commented on it, but I think there's a lot of value on our coronal imagings and even sagittal imagings. I know that we do reconstructions now routinely in a lot of our patients, and we use the coronals to look at the lungs, and we use our sagittals because we can look at the spine very well. Don't forget to look at your cardiac structures. Get used to looking at them in different, what I'm going to call non-conventional planes, which is conventional being axial for us radiologists. And then, of course, the 4-3-2 chambers views for the multimodality cardiac imaging. But those coronals and sagittals, we need to get used to looking at their cardiac structures as well. All right, so that's that case. Any questions about that one or any comments? That's the case that I kind of posted on Twitter yesterday. See if anybody could start thinking about it. All right, you guys are pretty quiet today. And then I think this is the other case. No, this is that one. It's an interesting case. So it's another post-op patient. I think it said they're 68 years old. Another show and tell, relatively straightforward. And let's see. So again, sternotomy. And then we see, okay, so this is a different case than what I thought. This is a patient with a bypass that required, you can see here, a Dacron graft attachment to that bypass, which we don't normally see on the coronary bypasses. We used to see those Dacron grafts going to the peripheral arterial surgical cases. And this is not the story that I had reviewed, so I don't have much of a history on why they had to go back and fix that bypass, to be honest with you guys. So those are the three cases that I had prepared. I think last time some of you had cases that we didn't get a chance to go over. We can do that today. So any of you back out there want to show a case?
Sure, I can show a case.
I knew you were going to show one. So thank you so much, man. Let me make you make you presenter. You ready?
Yeah.
All right. You should be getting a box there on your screen asking you if you want to take over.
Give me 1 second.
Sure. And make sure we're HIPAA compliant. So make sure that you are not showing patient identifiers, as you well know.
Yep. I'm not able to share my screen for some reason. It pops up that box that you sent me, but it is taking me to, it's telling me I have to restart the GoToMeeting app to apply changes.
All right, you want to do that, and I'll show a case in the meantime.
Sure.
All right, perfect. Thank you. All right.
Okay,
great. Thanks, Sandeep. So while we were trying to do that, I got a chance to get that other case that I was talking about. So this is also another patient post-op. It's a different patient though. All right. CT of the chest, non-gated with contrast. You see there's a granuloma on the left lung, etc., etc. Some plaque already here in the aortic arch branch vessels and aortic plaque, quite a bit actually. And then we see this structure here anterior to the heart, some clips next to it, clips here next to the ascending aorta. And you can see here the contrast here in the lumen of that structure. So it's a partially thrombosed aneurysmal dilatation of an aortocoronary venous graft. So there we see it right where it goes. It's somewhat narrow at the very origin, at the proximal anastomosis with the aorta, mostly thrombosed. And you do see that there's a contrast in the lumen. And then distally, you can see there anteriorly where the clip is, the graft comes down and attaches in the LAD, mid to distal LAD. So it is patent, but it's probably not for much longer if that thrombosis continues, especially at its very origin. So it's a very, very nice case of an aneurysmal, partially thrombosed aortocoronary venous graft. Let's see what it looks like on the coronal. It's probably going to look funky. Let's see. So there it is. A lot of artifacts from those surgical clips. Again, not a great images as it was not gated. It actually looks gated. So there you go. An aneurysmal dilatation of a venous graft. All right, let's see if Sandeep is back. In the meantime, anybody there who wants to show a case? I see two Sandeeps connect.
Carol.
Hey, Carol, you have cases?
It's Carol. I do.
All right, fantastic. So let's start with you while we wait for Sandeep. So I'm going to make you presenter. Thank you so much.
Okay. Okay. Not sure if sharing is going to work. It worked last time, so
Yeah, without any issue.
Okay.
Did you get the box asking you to take over? Or should I try it again? It says that you're the presenter here. Carol, you're muted. I hope you know that, and you need to share your screen now. If it's asking you to, or I can try to make you presenter again.
I can't. I wasn't unable to unmute myself, and I'm unable to share my screen today for some odd reason. So I'll keep trying.
Let's try it again. Let's do it again. Let's see. I'll find you here, and I'm gonna make you presenter. And there you go. You should.
Yeah, it's something about my system preferences.
All right, so
I have to change something in my system preferences to access my camera.
Okay, so let's see if Sandeep is back.
Yeah.
He seems to be
I
back.
can give it a shot.
All
Let's
right,
see
let's
if
try
that's
that. And Carol, we can do the same thing with you while he presents.
Sorry, I'll try. Yeah,
If you
I'll
want to,
try later.
exactly. Let's, if you want to change your preferences while he presents, we can do that. All right.
Okay.
Is it working now, Sandeep? I sent you the note.
Give me 1 second.
Uh-huh.
Do you mind sending that one more time? I keep getting the same message.
Oh, all right. So I have two with your entries with your name now. Let's see if this one works. Maybe I sent to the wrong one. Do you get it?
Yes.
Okay.
Hopefully this works this time. Can you see my screen?
Yeah. There you go. Fantastic.
Okay. Sorry about that.
No, thank you for sharing. Oh,
My
you made a
study.
PowerPoint. That's great.
All right. Hey everyone, my name is Sandeep. I'm one of the radiologists at MGH, and today I'll be showing two cases. My case one is a 59-year-old who had a prior history of ACE aortic dissection and underwent an aortic repair in 2009. And here is a post-operative CT scan that was done just before discharge. Here is a oblique coronal image that shows that they have repaired an aortic valve and also ascending aortic repair. You'll see a little bit of fluid around the aortic ascending aorta and some post-surgical changes, some sternotomy wires, and that's about it on this image. And moving on, so this patient did not have a follow-up, but he did have two non-contrast chest CTs as part of nodule workup that I'm not going to show you because this is NASCI, so I'll stick to the cardiovascular part of it. Then we finally get a chance to see some post-operative imaging. But here is how it looked at the baseline after the aortic root repair and a repair of the ascending aorta. There is a little bit of fluid around the ascending aorta going all the way to the arch, and you see that there is a residual dissection in the arch extending down to the descending thoracic aorta that you see with my mouse here. And we also get a look of the aortic valve. On the non-con, you can see that this is the post-operative Dacron graft material, similar to what Jacob was showing earlier about the cabbage graft that you also. So here is the follow-up CT after an initial period of when the patient was lost for follow-up. He came back for a follow-up CT to look at the ascending aorta again, and now we see something unusual. We see a few things here. One, there is now a contrast stabilization, which is very focal, appears to be confined within this so-called sac that surrounds this ascending aorta. And I'm going to show you how it looked on the MPR view. So that seems to be the origin of this contrast stabilization, which is very focal and confined to this sac. It did not appear to go outside the confines of the sac or extend into the pericardial cavity. So this was called as a focal graft dehiscence with contained leak into the excluded sac size. Now, it is very important when we read these follow-up exams to go back, take the effort to pull up that op note, which is very crucial, to see how the aorta was repaired and what happened to the excluded sac size. Sometimes the excluded native aorta is just incised, aortic repair is conducted, and then they will stitch back the native aorta on the top of the Dacron graft, which was the case in this patient. And so this outer wall here is the excluded sac size that represents the native aorta, and the inner lumen here is the repaired aorta with the graft, and this contrast is what we don't like on this scan alone. So there was a lot of discussion about what is the best way to treat this. The patient was not an operative candidate at this time point. So an intervention was done, and here is the intervention. I'm going to pause it where the intervention is shown. So this is the intervention. So what you see right now here is, again, you see that leak within the excluded sac size. Again, it is very focal, and you see an amplatzer plug that was used to plug that focal dehiscence at the anastomotic site. And you also notice that the sac size seemed to have grown, which is equivalent to an endoleak, but we don't use the term endoleak in cases of open repair. Here are some 3D volume rendered images showing that amplatzer plug. And by the way, if you're looking for inspiration and if you're feeling low because what's happening around us, check out Kurt Amplatzer biography on the Minnesota Historical Society. There is an entire recorded audio interview which I found very inspiring. Anyway, not to digress. If you look at the size of the ascending aorta and the sac around it, and you plot a graph, it continued to expand, and as big as 9.5 centimeter at one time point, which is this time point right here, where you see that there is tremendous growth now, and you again see this device. But again, with the device, if the device had worked, you should not see any flow in this excluded sac, but we continue to see flow. Ultimately, it was decided that it is not safe to leave a 9.5 centimeter excluded sac size, which is growing. So high-risk consent was obtained and patient underwent surgery. Here is a post-operative scan where you don't see the device anymore. There is some fluid around the aorta, but this was immediately post-operative, and sometimes up to 8 weeks, it's okay to see some fluid around the operative site. And here are some pictures of the explanted amplatzer plug, two views of it, courtesy our pathology department. My next case is this incidental finding on a cardiac CT, which was done to specifically look for coronary artery disease. And in here, you can see multiple low density foci that are marked with some of these ROIs showing you the hospital units, but I'm going to show you a minimum intensity projection image in a sort of a two-chamber oblique view. And you can see that they are sort of in the mid-wall approaching the subepicardial aspect of the myocardium. So they are not ischemic in etiology. Also, they might appear much more globular and rounded in comparison with how a sequel of an infarct would look like, which would be much more curvilinear or semicircular in shape. Going back to this patient's history, the patient came to the hospital a couple of months ago with this lesion. The problem at this point of time was stated as back pain and or abdominal pain. And here is the cause of that back pain. If you note carefully, there are multiple areas of hyperdensity. So this is an AML that had bled, causing a retroperitoneal hematoma. So how do we put two and two together? So we have renal AMLs and we have fatty foci in the myocardium. And the correct diagnosis here is a tuberous sclerosis complex. So tuberous sclerosis spectrum can involve multiple body systems. In the brain, you can have cortical tubers, benign white matter lesions, subependymal nodules, dense elastocytomas. In the chest, you can have cystic lymphangiomyomas. You can have rhabdomyomas in the heart. You can have multiple aneurysms, non-atheromatous stenotic lesions or ectasias. In the abdomen, you can have angiomyolipomas of the kidney and liver, adenomas of the liver and spleen. And in the musculoskeletal system, you can have bone islands, cyst and perosteal newborn formation. For the sake of completion, here is an antenatal ultrasound that shows a picture of a heart in this pregnant woman who herself is a tuberous sclerosis gene carrier. And you can see that this is the right ventricle, and you see a very echogenic mass lesion, which was appropriately called as rhabdomyoma. So why do we care about myocardial fat in tuberous sclerosis patient? Turns out it's a highly specific finding for tuberous sclerosis, specificity of 100%. Can be seen in up to 50% of the cases, and the number of fatty foci can correlate with the multi-organ involvement. So we went back and we counted how many fatty foci were there, and there were 14 in our case, and our case did have multiple organ involvement, including kidney and central nervous system. I think that's all I had. I'm happy to answer any questions if anybody has any. Thank you.
No, thank you. Those were great cases. Anybody has any comments or questions? All right, so let's see, Dr. Denny. All right, Carol, let's see.
Okay, we'll give it another shot.
Yeah, let's see if we can make this happen.
Okay. I think it's happening again. I did quit GoToMeeting, and I'm getting the same message again.
All right. It was
So, sorry guys.
No,
I
that's
was
right. We'll
able
do it
to the
next.
last several times, and today is not happening.
Yeah, no worries. Anybody else out there who wants to show a case? Okay, so with that, then I want to thank everyone for joining us. We're going to be posting these cases on the NASCI website, hopefully in the next couple of days, for everybody. If you want to go back and see some of the cases or review some of the stuff that we discussed, and we'll hopefully see you guys next month for another session of NASCI's Curious Cases webinar. Thanks, everybody. Please stay safe out there. Like I said at the beginning, keep your eyes open. Register for the NASCI annual meeting coming up in September. Really looking forward to seeing you guys over there. All righty. Take care, everyone.
Thank you.
Well, thank you.
Thank you.